Toni, are you on? I am. Okay, perfect. All right, everyone. Good afternoon, and thank you for joining us for part one of Deconstructing SBIRT Coding and Billing webinar. My name is Laura Grendal, and I will be moderating this series. We have muted everyone's microphones for this presentation. Hey, can everybody hear me? I know we're having some technical difficulties. We're good.
I can hear you.
Okay, perfect. Sorry about that. Hey, Laura, can you redo the intro just so everybody can hear it? Yeah, perfect. Not a problem. Good afternoon, everyone, and thank you for joining us for part one of Deconstructing SBIRT Coding and Billing webinar. My name is Laura Grendal, and I will be moderating this series. We have muted everyone's microphones for this presentation. However, question asking is encouraged. If you have a question, we ask that you add these to the comment field, and they will be answered during the Q&A at the end of the presentation. It is my pleasure to introduce Toni Elhoms. Mrs. Elhoms is a nationally known speaker and educator with credentials from AHIMA and the AAPC. She has expertise in both inpatient and outpatient coding, compliance, billing, and reimbursement. She has worked with hundreds of Title X and public health agencies and school-based health centers across the country. She leads and mentors a network of coders across the United States. Toni, I will now turn the presentation back to you.
Thank you, Laura. Thanks for that warm introduction. Okay, so Welter Associates is very excited to partner with Colorado Department of Public Health and Environment to assist school-based health centers with implementing SBIRT coding and billing practices. So this project encompasses many elements, and I want everyone to be aware of those elements so that we can make sure you're taking full advantage of the resources that you have. So our scope of work includes on-site audits with school-based health centers, those agencies that have signed up for their on-site audit. I will be visiting you, and we will basically walk through the process of implementation for SBIRT and help you be acquainted with all of the resources needed to do so. That registration is closed, so if you were not able to take advantage of that, there will be plenty of other resources. So also introduction to the electronic audit tool. So we have devised an audit tool exclusively for school-based health centers. That will be introduced and described extensively at our part 2 session. And then we're also conducting 2 web-based trainings, our training today and then our training in May. And they will all be recorded and accessible immediately following the scheduled training. So we'll have those up on our website. We'll have those up on our YouTube channel. Laura can actually send that information to you as well. So if you need that, just let us know. And then post-training surveys. So we are very interested in your feedback and making sure that you get as much out of this training as possible and this project. And so if you could give us your feedback, we would very much appreciate it. And then a training manual will also be developed and introduced to you all as part of this project. So you'll have access to that. And really the training manual and the electronic audit tool serve as roadmaps for successful implementation. So the overall goals of our project: correct coding and reporting of SBIRT services. So making sure that you're compliant with the CPT codes that you're reporting, the diagnosis codes that you're reporting, and also that you have all of the clinical documentation elements that are included in these codes to make sure that you're compliant. So really, in my mind, I like to focus on the 3 C's. So being able to code these services appropriately, feeling confident in your knowledge of how to apply these codes, and then most importantly, you're doing so compliantly. So coding confidently and compliantly are the goals of this project. And if at any point you're ever feeling overwhelmed or trying to figure out exactly how to wrap your head around this, just focus on these 3 C's, because that's really what this is about. So today we're going to talk about what SBIRT is, how it looks from a clinical documentation standpoint, from a coding standpoint, really what the goals of SBIRT are, and then how to appropriately report SBIRT services. So we're going to look at CPT codes. We're going to look at some ICD10 codes. I will tell you that there are many, many options with regards to reporting ICD10, and then the clinical documentation concepts. So these are all things we're going to zero in on today. SBIRT. As many of you know, SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. So anytime we talk about SBIRT, that is what we are specifically referring to. And this is an evidence-based practice used to identify, reduce, and prevent use, abuse, and dependence of alcohol, illicit drugs, and we're also going to talk about tobacco. So everything that you can do to help your patients with their risk reduction and practices. If you are just joining the line, I ask that you mute the line just so that everybody else does not hear the background noise. And then keep in mind that this is a recorded line, so when folks are listening to this, they probably do not want to hear any background noise. So if you join, please mute yourself. The SBIRT model was incited by an Institute of Medicine recommendation to look for a community-based screening health risk behaviors and substance use. Essentially, the goal is comprehensive, integrated health approach to the delivery of early intervention and services for people with substance use disorders, as well as those that are at risk of developing these disorders. So the patient populations that you're dealing with could have a lot of risk factors for developing these disorders, and that actually does factor into the equation. So screening, this is your assessment that the patient has risky substance use behaviors, and this is typically done with a standardized screening tool, and we'll talk about examples of acceptable screening tools. Brief intervention, so this is where you as the provider are engaging the patient that is showing risky behavior, and this usually entails a short conversation where you are providing feedback and advice based on what the patient has told you. And then referral to treatment. So this is where you're referring to either brief therapy or additional therapy depending on the needs of the patient. So those that screen positive and need additional services, you're taking the initiative to coordinate the referral for treatment. Every organization looks a little bit different as far as infrastructure and the providers that you have access to. So all of this information will certainly be contingent on those variables. So as far as screening, we really look at for SBIRT the 5 A's. So the first part would be the ask. So when was the last time you had alcohol? And then there are some parameters as far as what qualifies for a positive screen, a negative screen, and then what to do. How many drinks do you have per week? There are limitations on those and parameters as far as what's acceptable. And then do you use smoke or any form of tobacco? So these are some questions to ask. Obviously, this is not all inclusive. It should be based on the substance, whether that's alcohol, drugs, or tobacco, and what would be clinically appropriate for that. A lot of providers ask, well, why should we screen for these things? Research and studies show brief motivational conversations with patients promote significant and lasting reductions for risky use of alcohol, tobacco, and other drugs. So it's stated that nearly 30% of Americans engage in risky practices, but few actually participate in a conversation to address the issue because they're not diagnosed. So ask, assess. So once you've got a positive on your screen, you would want to use a brief assessment instrument. We'll talk about what those are to make sure that you are addressing the patient that has been identified as positive. So hazardous use, harmful use, possible dependence, and then there are some specific scoring tools. So audit, DAS, those are really designed for your adult populations, and then you guys will be dealing mostly with craft. It's probably something that you've used currently or have seen and been familiar with. And then the appropriate action would need to be taken based on a positive assessment. Negative. So, they did not screen positive. They came back negative. You would just want to reinforce positive decisions and making sure that you're rescreening at least yearly, ideally at the annual exam. And then more frequently, if you're dealing with any pregnancy or contemplating pregnancy, adolescence, any of the transitional periods that they go through, if there are any increased psychosocial stressors like poverty or factors at home that may influence their overall health, and then people with substance use problems who have recently changed their behavior. So keeping in mind all of these factors when you're treating your patients. And then patients with hazardous or harmful use. So the third A would be advise. So feedback, giving your recommendations as far as health risks for consumption of alcohol or other substances, and then any associated health problems that could be related to these, and then supportive feedback. So, at this level of consumption, you're at increased risk for health problems, just reminding them, and then, of course, advising them to cut back or abstain altogether. And then the substance will certainly drive the conversation even further. Patients with possible dependence. So you've identified that there could be a dependence scenario, and you would want to discuss the health risks of consumption for alcohol or other substances, provide clear and supportive feedback. So I believe you have, alcohol disorder, and it's strongly recommended that you quit, and I'm willing to do everything that I can to help. And then assess what the patient's willingness is to make a change. Brief intervention and referral to treatment. So this is really where you're arranging that next step as far as interventions for the patient. So goal setting, and you can do that by motivational interviewing. So how open are they to changing and taking the necessary steps to change their habits or cut back, and then assisting the patient in developing a plan so that they can quit or cut back or whatever the plan has been mapped out, potential barriers, and a plan for overcoming those barriers and establishing a good support network. Also follow-up. So continuity of care is really important, especially when you're dealing with these patients. So at each visit, or each time that you encounter them, you'll want to ask them about their current use and their progress with their plan. If they've been on an established plan, reinforce positive change, maybe make some tweaks to the change or the plan, and then referral if they're not meeting their goals. So escalating to what you think is most appropriate for the patient. If a patient is not willing to work on change, they're not open to the idea, you will want to continue monitoring and supporting that patient. So maybe it's just not the time, and providers are advised not to be discouraged because the patient may at some point become willing to work on these issues. And then communicate your concern for and willingness to help your patient. And then if they are willing to work on change, again, that referral, brief therapy, assist and arrange. So if you have infrastructure in place, maybe you have an LCSW or a counselor that you have access to that you can warm hand off your patient, that would be ideal. And then if not, you have a clear idea of what the resources are for your patients if you do not have that kind of infrastructure in place. Follow-up contact by phone or in person based on the patient's risk level. And then if you need any special consent, that would need to be obtained as well. So really the goal is continuity of care and making sure that someone is following this patient and not allowing the at-risk behaviors to go without care. So when can you ask these questions? When are good opportunities to screen your patients for alcohol, substance abuse? You can do this as part of your annual exam. So the well child check that you provide once a year or more frequently depending on the age group that you're dealing with. And then the acute care visit. So if they come in for a sick visit, that's also a good opportunity to ask the questions related to SBIRT. If you're seeing patients that maybe you haven't seen in a long time, are likely to drink or be at risk for smoking cigarettes, you'll definitely want to screen them for any potential risk factors. And then depression, anxiety, any associated conditions that would increase their risk, ADD, ADHD, conduct problems. These are all things that would clue you in to potentially asking the questions. Health problems that might be alcohol related or substantial behavioral changes. So increased combative behavior, mood changes, loss of interest, and that kind of thing. So ideally the workflow for your patients would entail asking the 2 screening questions, and we'll talk about what those are based on the age group, guiding your patient based on his or her response. So depending on how they respond to the screening questions, you'll want to tailor the message based on that, assessing the risk of your patient, advising and assisting, and of course that continued monitoring and support. So that's really the ideal documentation workflow, clinical workflow as far as SBIRT reporting. So for elementary school, ages 9 to 11, they recommend that you do the friends question first and then the patient-specific question. So do you have any friends that are drinking? Have any of your friends ever had beer or wine in the past year? And depending on how they respond, you would want to tailor your message. And then risk stratification based on what their answers are. Patient, have you ever had any sip of alcohol or have you ever drank alcohol? And then tailoring the message. Middle school, so that's going to be ages 11 to 14. Again, that friends, do you have any friends that are drinking? And then patient specific, how about you in the past year, or how many days have you consumed alcohol? And then stratifying risk based on the age and the frequency. High school students, ages 14 to 18. Patient, how many days? So how many days in the past year have you had, a sip of alcohol or more than a sip of alcohol? And then the friends question, if your friends have had alcohol, how many drinks? And do they usually drink for, an occasion? And then tailoring the message based on the findings. So clinical documentation elements, those are the things that we're really looking for as far as how you're treating the patient and the continuity of care. Then we dive into the code. So we've got our clinical documentation, which is extremely important, and then we also have our codes, which will need to be reported to the highest level of specificity and also backed by clinical documentation. So why are codes used? Codes are used to report the language of reimbursement. This is how we communicate to the payer what we did, why we did what we did, and making sure that we're meeting our local coverage determinations, our medical necessity requirements, and seamless communication with the payer for reimbursement. So coding allows payers to evaluate resources, to analyze quality measures and metrics, and then assist in the treatment of conditions. So anytime you're providing a service, you will want to make sure that you're reporting correct codes. So the code sets that you'll be working with for SBIRT are the ICD10 code set for your diagnoses, and then the CPT code set for your procedures. HCPCS, you may use those as well. There are some specific HCPCS codes for Medicaid, which we're going to talk about. Many HCPCS codes function as payer-specific code requirements. There are also supplies and other things that are involved in HCPCS. So CPT, that's our current procedural terminology, and this defines what happened at the encounter. These codes are always 5 digits, and they can describe anything from an office visit to surgery to SBIRT. So the CPT code is really important and should be represented based on the clinical documentation elements. So code selection should always be based on the documentation requirements for each service. So procedures, evaluation, and management services, they all require very specific things as defined by CPT. So an example would be a patient received smoking cessation counseling. So in the event that we actually had proper time documentation, this would be the CPT code 99406 that would be reported to reflect smoking cessation services. ICD10. So these are our diagnosis codes, and these codes are 3 to 7 characters in length. It is very important that you use the appropriate number of characters, because if you do not, your code would be considered invalid. This tells the insurance company why the patient came in for services. So the what is the CPT, the why is the diagnosis code. The first character is always going to start with a letter, and each character describes a field. So alpha characters are not case sensitive, and we'll talk about exactly what that means. F12.10, this is an example of an ICD-10 code to reflect cannabis abuse uncomplicated. So this is just one of over 68,000 codes. So who is ultimately responsible for coding encounters in your organization, specifically in your school-based health center? I've worked with many health centers across the country, and the majority of instances, the providers act as the first-line coders. They're really the ones that are in charge of picking the correct codes, and then they may or may not have some involvement from coding and billing staff to give them feedback or make suggestions on changes or documentation elements. Most of the time in your setting, providers act as the first line coders. But if you're not sure, I would advise you to ask this question so that everybody has a clear understanding of who is responsible for coding these encounters. So SBIRT services encompass smoking and tobacco cessation services, as well as alcohol and or other substances outside of tobacco, structured screening, and brief intervention. So the codes that we'll be working with are in these 2 sections of CPT. Smoking and tobacco cessation services. So there are 2 CPT codes to reflect these services, 99406 and 99407. These are the codes that you would need to report if the provider is rendering cessation services, and they've documented the total face-to-face time in counseling. These codes can be reported in addition to a well visit or an acute visit. So these are not standalone codes. Your patient didn't come in asking for smoking counseling. You are making that decision as a result of the visit that they were already here for. Individual behavior change intervention services are counseling and or intervention services directed at high-risk behaviors. That's really the focus of these codes, and the services can be reported as treatment of the condition or in relation to the condition that has the potential for causing illness or injury. So it can be for a defined reason, or it could be for the reason that there's a potential for the patient to develop. Intensity of service is defined by the total face-to-face time spent counseling on smoking cessation services. So let's say that your patient is here for an acute visit and they screen positive for smoking or tobacco, and you are going to make a intervention based on that finding. If the intervention is less than 3 minutes, so you did not spend more than 3 minutes outside of your evaluation and management service, this would be inclusive to your evaluation and management service. So for example, if you're billing a 99213 and as part of your documentation, you have stated that you spent 2 minutes talking about smoking cessation, there is no additional code to report the E&M service and the tobacco cessation. That would be considered inclusive. In the event that you spent a minimum of 3 minutes discussing counseling and cessation services, you could report 99406. So this code reflects 3 to 10 minutes of time spent exclusively on tobacco cessation services. If you spend greater than 10 minutes, you would want to report 99407. It's extremely important that your clinical documentation reflects total face-to-face time spent on counseling for these services, and that it's abundantly clear that these services were carved out separately from your evaluation and management service. So if you mention in your note that you did smoking cessation, but you do not quantify the time spent specifically on that, your code will be bundled into the evaluation and management service. Clinical documentation elements. The service must be provided by an eligible rendering provider. This service must be performed by a nurse practitioner, a physician assistant, or a medical doctor. So they must be an eligible rendering provider. These services may not be performed by RNs or nurses or medical assistants. Plan documentation should demonstrate development of a patient-specific plan to change behavior with appropriate actions and motivation. So the patient-specific plan is really what's going to define the medical necessity for the service. Then, of course, the total face-to-face time in counseling. Alcohol and or other substance. So this is where we're actually getting into our screening brief intervention specific codes for alcohol and other substances outside of tobacco. So we have 2 code selections here, 99408 and 99409. And these are based on total face-to-face counseling time for the encounter. We also have some HCPCS codes. So the HCPCS codes are the codes that start with letters. So H0049, H0050. These are 2 codes that are really for data capture purposes. H0050 is not a payable benefit for Medicaid, and these are Medicaid-specific codes only. So really, it's a data capture goal here. In the event that you spend greater than 15 minutes providing screening and brief intervention for alcohol or drug services, you would want to default back to reporting the 99408 or 99409, depending on how much total face-to-face time. Individual behavioral change intervention services are counseling and or intervention services directed at high-risk behaviors. So again, the diagnoses, the medical necessity would need to support why you're using the 99408, 99409 code. The services can be reported as treatment of the condition or in relation to the potential of the condition developing. The intensity of the service is always defined by total time spent in face-to-face counseling on the screening and brief intervention services. So in the event that you've spent less than 15 minutes on your screening and brief intervention, for Medicaid only, you have the option to report H0049. If you spent 15 minutes with the patient on SBI, you could report for Medicaid only H0050. Keep in mind, H0050 is not a payable service under Medicaid, so if you receive any kind of denial, that is why. 99408 and 99409 are payable services, and those would be reflected if you spent greater than 15 to 30 minutes or greater than 30 minutes. Again, the code selection is based on the total face-to-face time. Clinical documentation elements. So there are quite a few more elements that would need to be documented for these services as opposed to the tobacco cessation services that are a lot more simple. So the service must be provided by an eligible rendering provider. Again, going back to who is able to render the service and actually bill for the service. Validated instruments to determine the patient's opinion related to behavior change. The plan documentation will need to be patient-specific to understand what the plan is on how to change behavior, what the actions are, and the level of motivation of your patient. Also, the total face-to-face time in counseling. That's, again, what really drives the code selection. Examples of structured screening tools. So there are many versions that you could use, Audit, DAS-10. Those are really designed for the adult population. You've also got the CAGE questionnaire. And then CRAFT, which is specifically designed for adolescent alcohol and drug use. So I have put a couple of examples of what these structured screening tools look like, and I will jump to the CRAFT because that's the one that you guys will probably be using most. So I'm going to ask you a few questions that I ask all of my patients, and these we would really appreciate if you would be honest, and we will keep your answers confidential. So that's kind of a recommended intro so that your patient is comfortable answering the questions. During the past 12 months, on how many days did you, and then of course the 1, 2, 3, the questions are specific to the substance, and then you have specific directions based on how many positive answers you get in part A. So I'm sure many of you have seen this tool before. This is a specific tool that would need to be documented in the encounter for that day to support 99408 or 99409. Despite the high prevalence of mental health and substance use issues, too many Americans go without treatment, largely because the conditions or disorders go undiagnosed. So the goal of SBIRT is really in that primary care setting, school-based health center setting, pediatric setting, that we're detecting things and making sure that we provide the correct interventions. Regular screenings enable earlier identification of mental health and substance use disorders, which translates into earlier care. So SBIRT requires very specific ICD10 codes to be reported in addition to the CPT codes. So we'll get into the ICD10 coding concepts, and I will warn you guys, this is where it can get very confusing. So you will need to have access to either a ICD10 coding book or a coding software. Many electronic health records have codes built into their software. I will caution you that some of the codes are not accurate as far as the descriptions, and you'll want to make sure that you're using the appropriate code, and if your descriptions are not correct, you could potentially not be selecting the correct code. So I do have some recommendations on how to streamline that process, and I will go over those right now. So the structure of the book, we've got our conventions, we've got our guidelines, our alphabetic index, and our tabular list. if you use an ICD-10 book to manually code, this is how the book is structured. It's actually really important because there are many conventions and guidelines that many people are not aware of that can be the culprit for claims denials. You always want to code directly from your tabular and never from the alphabetic index. Why? Because the alphabetic index does not have the complete code selections and all of the specificity options. Keep in mind, ICD-10 codes change every single year. On October 1st, annual updates are incorporated and you must report the correct codes starting on October 1st. So make sure that you have that in your calendar just so that you know new codes happen on October 1st and you'll be required to report those new codes on October 1st of each year. How do you look up a code? You go to the alphabetic index, you locate the condition, disease, or term in the alphabetic index, and then you'll go to the suggested code in the tabular, and that will help you drill in on what specific code you may select. So you'll want to look at the 3-digit code category. You'll want to look at the code descriptions and noting any inclusion terms or excludes notes. We'll talk about what those are. And then assign all required additional digits. So if your code requires 7 digits and you're only assigning 5 digits, your code is not valid, which means you will definitely get a claims denial or a kickback. In the event that you do not want to use a coding manual, ICD10 Datacom is a great free resource that will allow you to pick your codes based on your search term, and then you can actually take the physical code and plug it into your EMR. In the instance that your EMR is not helping you or is making your life extremely complicated because the lookup is not helpful, this can be a great bypass as far as how to be more productive and efficient with ICD-10 coding. Code structure. So you will need to understand the fundamentals as far as the structure. So our category is represented by our first 3 characters. Then we have our decimal. It always comes after the 3rd character. And then our 4th, 5th, 6th, and 7th characters are contingent on the chapter for which you would be reporting. The most important thing to remember is that if your code requires 5, 6, 7 digits, you must report all digits. Unspecified. So there are still unspecified codes in ICD-10. Many reported unspecified codes in ICD-9, and essentially that led to many sloppy coding practices, because essentially unspecified in ICD-9 meant I don't care, whereas in ICD-10 it means I truly don't know. So in the event that you're picking a code based on unspecified in ICD-10, you're really telling us I don't have any additional information to provide. And in the instance that that is the case, you truly don't have any additional information to provide or additional specificity, it is acceptable to report unspecified. If your clinical documentation lends to the fact that you do have additional specificity, but perhaps your code doesn't reflect the specificity, you're basically not reporting the correct code. So you're not adhering to coding guidelines. We would like to avoid that if at all possible. The goal of ICD-10 is to capture as much specificity as the provider can. In ICD-10, there are 2 excludes 1 and excludes 2 notes. These are very important, and I'll show you what that looks like in just a moment, because in the instance where you report diagnosis codes that are exclude 1 or exclude 2, you could potentially get a kickback or a denial from a payer because it's not following correct coding guidelines. So excludes 1 means that you cannot code 2 conditions together. Excludes 2 means exactly the opposite. You can code 2 conditions together. So I'll give you an example. We've got F32. This is a category, not a code, a category for major depressive disorder single episode. So we've got our excludes 1, which tells us we cannot code F31, anything in our F31 category, anything in our F30 category or F33 category with any codes in the F32 category. So if it is labeled under excludes 1, you cannot report bipolar disorder with major depressive disorder. You would need to pick the one that's most applicable for that patient. Excludes 2 means exactly the opposite. So you can report F32 or any codes in the F32 category with adjustment disorders, or specifically F43.2 to that subclassification 0.29. So Excludes 1 and Excludes 2 have a major impact on your clean claim. Includes notes. So these are also really important to understand. If you're looking in a code book, or if you're looking on ICD10 Datacom, you may see this stuff and wonder what it means. So Includes notes appear immediately under a 3-character category. So F32, our major depressive disorder single episode category, and it further defines or gives examples about what should be included in the category. So for example, for MDD, if they've got a single episode of depressive reaction, this would be included in this category. It tells you, okay, I'm in the right section, and these are the codes that I can report if the clinical documentation supports. Inclusion terms. So these are terms that are directly under codes, not categories, but codes, and they reflect conditions for which the code is to be used. So very similar to Includes notes, but the inclusion terms are not necessarily exhaustive. So there may be some things in here or some things that you would like to diagnose the patient that are not complete under this umbrella, and that's okay. Just keep in mind they're not all inclusive. So for MDD with psychotic features, it goes into more specific definitions of what that might look like. Not otherwise specified. So if your code says unspecified in the code, it's defaulting to a coding convention called NOS, not otherwise specified. A couple slides back, I talked about the difference between unspecified in the ICD-9 world and unspecified in the ICD-10 world. So essentially, if you see not otherwise specified or NOS, you are stating that you do not have any additional specificity to report regarding that condition. Not elsewhere classified. If you see NEC, it means that there's not a specific code for the patient's condition. It hasn't been defined. So that's really a catch-all in the event that there's not a specific code to identify what you would like to report for that patient. The good thing for you guys is that you'll only need to focus on 2 chapters of ICD-10. There are 21 chapters. The majority of the codes that you'll be dealing with for SBIRT reporting will be in Chapter 5, the Mental, Behavioral, and Neurodevelopmental Disorders chapter, and then Chapter 21, which is our Health Status or Z code. So they'll start with either F or Z for your diagnoses. The concepts are defined based on use, abuse, and dependence. So your diagnoses, every single one that you select for any of the conditions, will need to be categorized based on use, abuse, dependence. We're going to talk about what that means and the subclassifications of use. This table is really to demonstrate the hierarchy in the instance where patients have abuse and dependence. Maybe they have use, abuse, and dependence. Which one do you actually select a code for? So in the instance where you've got documented use and abuse, you would use the code for abuse. In the instance where you're looking at abuse and dependence in the same category, you would code for dependence. Use, abuse, and dependence, you would default to dependence. And then use and dependence, same thing, dependence. So the majority of the time you'll be reporting diagnosis codes that are classified as dependence unless they're meeting the parameters for abuse. These are coding guidelines. They're very specific to the ICD-10 coding requirements. So all of this information came directly from ICD-10 CN. The term use provides a mechanism for code assignment when a provider indicates a patient's use of substance but does not further specify that it classifies as abuse or dependence. So really use is a very general term for at the bottom of this scale, but doesn't really meet the criteria for dependence or abuse. So if you're not sure if it's crossed into the dependence or abuse category, use would be your default. Use has subclassifications. So when you're looking at the diagnosis code, you'll notice that they're defined by the subclassifications of use. continuous, episodic, remission, and unspecified. So in the instance where we're looking at continuous use, this would be daily or almost daily use of drugs and alcohol, and then the specific amounts of alcohol, and then how that looks on work days, on weekends, and then on off days. Episodic, so that's short periods between use, or in the terms of alcohol, binges that could last weeks or months, followed by long periods of sobriety. Remission would be a complete cessation of alcohol or drug intake for a period of time, during which a decrease towards cessation is taking place. And then unspecified is you don't know, or it hasn't been documented. It's perfectly acceptable to report unspecified if you do not know. Abuse. This would indicate withdrawal symptoms are not likely to occur when use is discontinued and is separately defined for drugs and alcohol. So different categories for drug abuse. This is going to be a pattern of drug taking and includes patients who take drugs illegally or in excess, but have not reached a stage of dependence on the drug. And then alcohol abuse, a problem drinking, and includes patients who drink to excess, but have not reached a stage of physical dependency on alcohol. Again, these are ICD-10 CM descriptions. Dependence indicates the provider's opinion that you anticipate withdrawal symptom or syndrome are likely to occur when use is discontinued. And whenever drug or alcohol withdrawal actually does occur and is documented, it will typically be coded as a significant comorbid condition, which would factor into the severity of illness. So F17 is a code category for nicotine dependence. This is not a complete code, this is just the code category. You'll notice there's an excludes one note that states you cannot code tobacco use, not otherwise specified, or history of tobacco dependence with nicotine dependence. Basically, F17 or whichever condition would be most applicable for your patient. Excludes two note states you can report F17 with tobacco use during pregnancy or a toxic effect of nicotine. These are some examples of nicotine dependence. So F17.210, 211, 213, 218. There are many options. And these are based on the type of nicotine. So is this cigarettes? Is this chewing tobacco? And then based on whether it's uncomplicated, in remission, with withdrawal. Again, these are all contingent on what you know at the encounter. And then cannabis abuse. This is just to give you a visual on what these codes actually look like. So a complete code for cannabis abuse in remission would be F12.11. These are not all inclusive. There are thousands, potentially tens of thousands of diagnosis codes that could be reported depending on your patient's diagnoses. There are also additional Z codes. These are the health status codes that I talked about to report instances where you are doing alcohol abuse counseling or counseling for a family member of an alcoholic. So this could be applicable to your patients. It does also state that you would need to use an additional code to report for alcohol abuse or dependence. So that would be if your patient also has abuse or dependence. There are specific counseling codes for drug abuse as well, so alcohol abuse, drug abuse, and then there is the additional code requirement to identify from the F chapter the specific abuse or dependence. Then we have our tobacco abuse counseling code. This is really a very generic code, and the most and more applicable code would be from the F17 category. It states use additional code for that. So you can use this code. Ideally, you would use the most specific code from the nicotine dependence category. And then tobacco use, again, a very generic code to reflect if a patient hasn't gotten into the categories of dependence or abuse. So keep in mind, unspecified codes, unspecified is perfectly acceptable if you do not have more information and your code reflects everything that you note at that encounter. Many carriers are potentially not reimbursing for unspecified codes, not codes that you would not have access to the information, but codes that you do have access to, but you may not be reporting the most specific codes. So just keep in mind, specificity really does matter. Some action items. So make sure that you're attending part 2 of our webinar or our web-based training series on May 10th. The registration link is in the slide deck. Laura has also sent that out, and you can contact her if you have any questions about registration. I will also be presenting at the CASBAC conference on May 2nd in Keystone, so if you will be there, I would highly recommend that you attend our session, as we will be talking about SBIRT as well as many other concepts. And then if you would fill out our post-training survey and send that back to Laura, we very much appreciate it and value your feedback. And at any point during this project or during implementation, if you're feeling overwhelmed or frustrated, just remember the 3 C's. You want to code confidently and compliantly. So that is really the overall goal of this program. And then resources. So our website will have the web-based trainings. You'll be able to access those. We'll also have those on our YouTube channel. And then SAMHSA also has some really great resources that I actually pulled from as part of this presentation. So I've included these links if you would like to look at any of their information. At this point, we'll take any questions that you may have.
Okay, Toni, we had one question. Can smoking and tobacco codes be used for vaping?
Yes, they can be used for vaping.
Okay, and the other question is, can you schedule a follow-up visit for teen just for tobacco counseling and bill for it?
I'm sorry, repeat that question one more time.
Yep. It said, can you schedule a follow-up visit for teen just for tobacco cessation counseling and bill for it?
Yes. So those tobacco cessation codes are not required to be reported with an evaluation and management service. They can be reported as standalone codes.
Okay. Next question. I just want to review and make sure it is fine for us to use code H0049 for positive craft with brief intervention less than 15 minutes at our school-based health centers. Is H0050 a viable code to use even if we can't bill Medicaid for it?
Okay, so both of these codes are Medicaid-specific codes, and I can definitely understand why these would be confusing. So H0049, you could use as a code to report the positive craft if it's less than 15 minutes. Yes, you can report that to Medicaid, and you should receive reimbursement for that. H0050 has no payable benefit, so you're more than welcome to report it, but you will not see any financial incentive or reimbursement tied to that code. I think it would be most appropriate if you're hitting the minimum of 15 minutes and you've got your craft documentation, it would be ideal to report the 99408 and 99409 CPT codes.
Great. Next question. If we use the craft, do we need another instrument to determine patient opinion RT change?
Not sure about that one. I will have to get some additional information.
Okay, I'll flag that and we'll send that out, or maybe circle back to that during part 2.
Yes, that would be great. And Catherine, I do see your question. If you'd like to add some context now, you're welcome to do that.
There was a place where you were talking about the criteria for charting for tobacco and drug education, and it said using a validated instrument to determine patients' opinions related to change, I believe. And so I was curious what that meant.
So the craft should encompass everything that you need to screen the patient.
Okay, perfect.
Okay, next question is, it was my understanding per HCPS SBIRT manual that H0049 should be used for negative craft screen. Are you saying it can be used for positive craft with brief intervention, 15 minutes? And that's from Maureen.
Okay, so in the instance that you have a negative craft that took less than 15 minutes, you could report H0049. That is correct.
Okay. And then Catherine had one more question, and it says, can a health educator do this education? And she was referring to the tobacco cessation, alcohol drug cessation.
So health educators are currently not eligible to bill for the services. So in order to be compliant with the billing, you would need to have either a nurse practitioner, a PA, or an MD or DO to provide that service.
Great. That does it for all the questions. And based on time, I think we're going to cut off the webinar now. But if you do have any additional questions, we ask that you send those back with your survey responses, and they will be answered during part 2 of this webinar series on May 10th. We thank you all again for joining us today. We look forward to meeting with everyone again for part 2 of the Deconstructing SBIRT Coding and Billing webinar on May 10th. If you have not yet registered for that webinar, we encourage you to do so now. Registration will close on May 5th at noon. A post-training survey will be sent out to all attendees following the conclusion of this webinar. Your feedback is very important to us. Please complete the survey and return it to us before April 26th. Have a great rest of your day, everyone.